Welcome to the OncoPT podcast, where you'll learn from oncology experts, practitioners, and patients to help you on your journey to become a confident and competent OncoPT. Here's your host, Elise Cantu.
Hey OncoPT, and welcome back to this episode of the OncoPT podcast. As part of our conference course debrief series that we're doing here at the OncoPT podcast, this podcast episode is going to blow your mind. If you did not see any of the updates that have come out of the ASCO 2025 conference this summer, you are going to lose your mind with the stuff that we are talking about today. Now, before we get into what that is, I need to welcome our guest for today, Scott Capozza. You've been on the podcast a few times. It was time to have you back. Welcome back to the OncoPT podcast.
Thanks, Elise. It's always great to chat with you.
Would you mind introducing yourself to the audience who maybe hasn't met you yet?
Sure. So again, I'm Scott Capozza. I'm a board-certified clinical specialist in oncologic physical therapy. I work in outpatient oncology up in Connecticut. I'm pretty fortunate that not only do I work in traditional outpatient oncology settings, but I'm also integrated into a multidisciplinary cancer survivorship clinic, as well as more recently, a multidisciplinary GI surgical clinic, which is more of the prehab side of things.
Yeah.
So I really feel, I'm really fortunate that I feel like I can see patients throughout the continuum of care: prehab, active treatment, survivorship. So
very cool.
That's who I am.
Oh my gosh. Okay, so we're talking today about the recent ASCO conference, and you were there as a presenter, and this is a conference that maybe some people have heard about, but maybe they haven't. So can we really quick establish what is ASCO, and therefore what is the ASCO conference?
Sure. So ASCO stands for the American Society of Clinical Oncology. And so just like we have APTA, which is our national governing body for us as physical therapists, the oncologists have their national governing body, and that's ASCO. And just like we have CSM every year, they have a large annual meeting where this year they had 44,000 people.
Holy cow!
In attendance. I can't remember what the number was from Houston this year, maybe 15 or 16,000. So that almost three times as many people, all packed into the McCormick Center, Lakeside in Chicago, Illinois. So yes, and it's incredible because you've got the surgeons, and you've got the medical oncologists, and you've got the radiation oncologists, you've got researchers, and it is international. So you've got people flying in from Japan and from Chile and from Spain, all presenting their most current research in oncology care. And so it can be a little overwhelming.
Yeah, I can
the
imagine.
First time, because just think about how overwhelming CSM could be sometimes.
Oh my gosh, yes.
Especially as a first-time attendee. So take that and triple the size of that. And I always make the joke too, Elise, that we always have fun in the exhibit hall, right? We go and everybody gets their free Theracane.
Yep.
And everybody, runs on the new 0G treadmill, that sort of thing. Their exhibit hall is like our exhibit hall, all jacked up on Mountain Dew. Because, for better or worse, you've got pharma there. And so you've got these huge stations, and they've got espresso bars, and they've got smoothie bars. And I was actually sent on a mission by my wife to go to the La Roche-Posay table to go get free samples.
Yes,
so yes,
absolutely. Okay, so it sounds like, if nothing else, the exhibit hall is definitely a first stop for me when I go to ASCO. So
absolutely.
So American Society of Clinical Oncology, they have their annual conference, which was held this past, so technically not last weekend, but the weekend before. So I think we said like around May 30th, June 1st. And it's quite a long conference is what you were telling me, right?
Yeah, people usually start showing up on Thursday, and they have
Mm-hmm.
some, kind of like almost like how we have like pre-cons
Yeah, yeah.
at CSM. So so people a lot of times show up for that, and then our good friend and the OG of oncology rehab, Nicole Stout. I know she presented the Friday on ASCO this year, and so. And it goes actually through Tuesday. I presented on Monday morning of
Mm-hmm.
ASCO, and they were still some breakout sessions on Tuesday. So it's a good, 5-6 day commitment
That
if
is
you're going to
so
go
intense.
for the whole thing.
That is so intense. But I mean, also with 44,000 people attending, and I mean, countless, countless presenters, I feel like you would be hard pressed to fit that content into the weekend conference that CSM kind of is. So
Mhm.
that's crazy. And it's an annual conference, right? It happens every year.
Yeah, just like for us, how CSM is usually middle February, ASCO, the annual meeting is always, it's usually the weekend after Memorial Day,
Hmm.
which is great in Chicago because it's just starting to warm up, but it's not
Yeah.
muggy yet. So this was my third time going to ASCO, and I've been pretty lucky. Every time I've gone, it's been nice weather there. But just like how we do also through APTA, that some of the sections have their own sessions or
Oh.
conferences, right? APTA Neurology does their own conference later on in the year. ASCO does the same thing. So they actually do have a very specific ASCO GI symposium that they run every January, which I believe is in San Francisco.
Hmm.
So, but just like, yeah, so ASCO annual meeting, the one in Chicago at the McCormick Center, is analogous to our CSM.
Nice. Now, do you go to this conference just for kicks and giggles, or like somebody's wondering in the audience right now, but you're a PT, Scott. Why are you going to the clinical oncology annual conference? Like, talk to me about that.
Well, so me personally, I've been very fortunate that each time that I've gone, I've presented or I've spoken, and ironically enough, 2 out of the 3 times I've worn my survivor hat there. In 2017, 2018, I went and I spoke as a survivor through the ASCO Voices program, where there's no slides, and it's really just an opportunity for people to kind of talk about the human side of oncology care. So that when I did ASCO Voices, there were 5 of us. They each gave us maybe 12 minutes on the stage, no slides. I was actually the only survivor. Everybody else were providers, and they were telling
Wow.
very humanistic stories about their practices and that sort of thing. So that is always a highlight. A lot of people like to go to that because, again, that's
Hmm.
the kind of the human side of
Yeah.
oncology care. 3 years ago, I was fortunate enough to go. The breast center that I work with, the providers that I work with, we had put together a poster. It was actually in reference to referral patterns for women with lymphedema.
Hmm.
And so I presented the poster there.
Nice.
And then this past year, ASCO 2025, again, I went back as a survivor. ASCO is really making a push to have more patient advocates involved.
Yeah.
And this is actually a funny story. So last fall, I get this random email from ASCO, and it looks pretty official, and it says, "Congratulations, you're going to be a speaker on this panel." I mean, at first I thought it was spam because I didn't apply for anything. I mean, I literally put it through our IT department and said, "I don't want to click anything because I'm afraid
Okay.
somebody's phishing me here." It's a phishing scam. And so, and so the IT department ran it through. They're like, "No, this is legit." And I said, "Okay, fine." And no, and it gets even better, Elise. It gets even better because so I click on it, and it's like, and there's 4 presenters, there's 3 oncologists, and there's me, and it has me as Scott Capozza, patient advocate. Okay, great. They want to hear the patient voice. Awesome. The patient voice needs to be elevated at all of these conferences. And that's a whole other conversation that you and I can have about making sure that we elevate the patient voice at our own conferences.
Right.
But anyway, so I go and I'm like, okay, fine. Go into the speaker center. So do my conflict of interest forms and the whole thing. And I look, and the panel was about oncologic care for patients with kidney cancer.
All right. Okay.
And I thought, that's not the cancer I had.
Yeah.
So I emailed the moderator and I said, so just so you know, I'm psyched that you've got a patient advocate here and that you reached out to me. I'm honored, but just so you know, that's not the cancer I had. And he wrote back and he's like, no, we need the patient voice. Like, we need to know, like, the decision aspect of it. Like, when you sit down, when the patient sits in the room, the medical oncologist or the surgeon, and they say, this is what we're going to do. What's going through the patient's head? We want you to do it that way.
Gotcha.
So anyway, so that was for me this year. But go back to answer your question about why should PTs go to ASCO and potentially other conferences that are not CSM. We're working with these surgeons. We're working with these medical oncologists. We're working with these radiation oncologists. They need to know that we're part of the team. So first and foremost, we need to be present. Second of all, we need to find ways to get even more involved and to present at these conferences so that, again, these providers know how crucial rehab is to their patients. And so we've had this conversation offline. I hate silos. It does not do anything for patient care. The patient feels disjointed, trying to go from one person to the next. And so if we can seamlessly work together, so that's why it's so important that, and then the other aspect of that is we, as OncoPTs, we need to know what's going on.
Exactly.
We need to know what these new drugs are. We need to know what these new clinical trials are. We need to know how they're changing these protocols. There was one thing that they presented there, which I thought was interesting. There was a study that came out about potentially omitting carboplatin from neoadjuvant therapy for women who are HER2 positive for early stage breast cancer. Great, awesome. That's great. We definitely don't want, if they can take carboplatin out of it and we still get overall survival rates, that's fantastic. Another study that came out this year, it was the Destiny Breast 09 study, was, again, they're tracking overall survival and progression-free survival in patients. And so they found that Tanuzumab deruxtecan, which is the TDXD, plus Pertuzumab, it gave patients an extra 13, 14 months of survival for patients who have metastatic breast cancer, which is awesome, right? We're giving these patients an extra year plus of life. How's their quality of life?
Yeah, exactly.
So if these patients are going to be able to switch to a different protocol and they're going to live another year or so, that's amazing. That gets them to their kids' high school graduation. That gets them to their kids' wedding or whatever it might be. But they got to be strong. They got to be able to get to the wedding. They got to be able to walk their daughter down the aisle. That's what we do. So we have to be cognizant of these protocol changes, new drugs, new clinical trials, because guess what? Our patients are going to look this up. And so they may very well ask us, what do you know about Destiny Breast 09? We got to know.
Yeah. And this is a really good point you bring up, as there was a lot of conversation, and I'm getting my information, like, there are different oncologists and other healthcare professionals on social media who were sharing their conference takeaways and whatnot, which was really exciting. And I don't know if I've curated my algorithm to really get this, or if more people were just on the ball of sharing these insights at the conference. It could be both, who knows? But there was much more like conversation happening that I could watch real time, as far as changing kind of the norm, or the expectation when it comes to overall survival that patients can expect when it comes to, different protocols and whatnot, which is really exciting. And the big but that Scott brings up here is, overall survival increases. What about that quality of life? What about their functional mobility, their independence, as they are living now longer, whatever that looks like for them? And who better to take that information and implement it into practice, not just with our patients, but also in conversation with our oncology teammates, right? To say, okay, I know that this might be happening, or, if this is happening in your practice, this is a consideration. This is how I can help fill this gap for your patients. How exciting. What an exciting time to be in oncology physical therapy. Like,
Yes. And we're gonna talk about the Holy Grail in a second, but there's one other
oh my God.
breast specific one I want to make sure, again, because we've got to be aware that the oncologists they have their own guidelines, just like we have EDGE Task Force guidelines for us as OncoPTs. They have their own guidelines. And so there was something they're going to be trying to move. There's new evidence that shows that in select patients with early stage breast cancer, they're now talking about getting rid of sentinel lymph node biopsy. Right?
What?
So talk about, again, quality of life. If these patients don't need to have, never mind an axillary lymph node dissection, but if they don't have to have a sentinel node, again, very specific population within the breast population. But can you imagine, like, that, again, that's going to significantly change the landscape of how we see these patients, because, okay, well, if they don't have the lymph node dissection, what does that do for their, it helps lower their risk of lymphedema.
Exactly.
But again, patients are also very savvy now, and so they're going to look this up, and so they're going to come to us. They're going to come and they're going to have these questions ready to go, and so we have to be prepared. We have to do a little bit of homework ahead of time, and again, think outside of our PT box so that we can speak oncology across the board.
Right. We've alluded to the Holy Grail a few times now. I think it's time to bring out the big guns, Scott, because there were lots of things coming out of ASCO this year that were just really, really exciting. But this one, I don't know that I even have words to convey, like, how big of a deal this next piece of, like, literature and whatnot that came out. So let's just get into it, Scott. Tell us, what is this Holy Grail that we keep talking about?
So it's the Challenge clinical trial, which is based out of Canada. It involved patients both from and researchers from Canada and Australia. And it was an exercise trial for patients with stage 2 and stage 3 colorectal cancer. And they ended up enrolling almost 900 people over the course of it was from 2009 to 2023, so for like 15 years. So it was a long time, and they tracked these patients for years after the intervention. So a significant study, a lot of time and effort and resources went into this trial. So incredible work. And so what they did was they had their intervention was patients were either randomized to an exercise group or like what they call like a health consultant group.
Okay.
So the control, the health consultant group, basically got the piece of paper.
Yeah.
To say, go exercise.
Mm-hmm. Exercise good. Go do on your own. Good luck.
Yeah. The intervention group met with what they called a physical activity consultant. You can very easily submit in their physical therapist. And they met with the consultant, this physical activity consultant twice a month for 6 months. And then they space it out even more over the course of 3 years to still meet once a month. So they still had that touch point. They had that touch point to, see how they're doing, change anything if they needed to. It helped with adherence, it helped with, being able to follow up with these patients. The patients didn't feel like they got lost through this whole thing. So incredible. So they looked at the numbers, and so what they found was that the group that was in the structured exercise program, again, structured, some level of supervision, somebody is watching them and motivating them and modifying these exercises. They found these patients had a 28% lower risk of recurrent cancer or new cancers, right? So over a quarter of these patients, it lowered their risk of recurrence.
It's incredible.
By exercising, by moving. And it gets better.
Yeah.
If you can believe that,
Yeah.
that's incredible, right? Right there, they've got the evidence. It gets even better. Like they track these patients, and after 8 years, they found that these patients who were in this trial, it lowered their risk of death by 37%.
Yeah.
1/3.
Yeah.
It reduced their risk of death from their disease. And to put the cherry on top of this whole thing, these outcomes, right? 28% lower risk of recurrent cancer, 37% lower risk of death, was better than some chemotherapy regimens.
That was my favorite part of opening the trash fire that is social media and seeing that graphic. And I don't know if it was Dr. Liz O'Riordan or Dr. Toplinsky that I saw it from on social media, but they posted that chart that compared this. So in this trial, exercise against, again, it was different chemotherapy regimens that these patients oftentimes undergo, and exercise was better than some of that, which is insane to think about. And again, what a better way. Again, we've known this for a while here on the OncoPT and in cancer rehab. Exercise is really good for people. There's numerous benefits, countless benefits that are supported in the literature time and time again. But to see such a resounding level of support in the evidence for what exercise can do for a person's survival and recurrence, I don't know how to communicate how groundbreaking this is. And maybe even groundbreaking is not the word that I'm looking for. This is truly a moment where we are at, I think, a tipping point in oncology rehab. To have such substantial, and we've had substantial information previously, but for this level of evidence to be recognized on a national and international level at ASCO of just how good exercise is for this patient population and more, as we can surmise, this is a point at which we as oncology rehab professionals can take this and run with it, or we can watch it pass us by. I believe this firmly in my soul, Scott. Now that's me. Tell me your thoughts on this, right? Like you're getting this information as it's coming to you live. Like, what are you thinking as you're listening and hearing this?
Well, first of all, it validates everything that we do.
Yeah. Yeah.
And now and by the way, this, when they presented this, like they got a standing ovation. So that just shows you that the doctors appreciate this now. They're like, wow, like this is seismic as far as to be able to, and that's the strength of this study. Almost 900 participants over 15 years. This was not some little pilot study somewhere. And obviously we need pilot studies, but this was not a pilot study with 20 people. This was 900 people.
And nearly 15
years.
Yeah.
So they have put a lot of effort into this. So this was presented on the Sunday of ASCO. Sunday night, I was able to meet with some of my providers that I work with, and I went right to one of my friends who's a medical oncologist in GI, and I was like, so this is the evidence we need so we can finally get our gym, right?
Right.
Yeah, and he was all jacked up. He's like, yeah, absolutely, because he and I have been advocating for a gym at his clinic for years now. So this is it. This is the evidence. This is, of course, everything it gets implemented, at different rates, at different places, but this does lay the groundwork for what we do. And, and this is movement, this is exercise, this is rehab. And then if you pull in nutrition,
oh my gosh,
are we talking a 50% reduction in risk of dying from your cancer? Like I'm sure that's coming next, and we're gonna have that evidence to say, okay, yes, rehab and exercise combined with nutrition, sensible nutrition, is going to be more efficient at preventing recurrence of cancer than drugs.
Right. And I honestly have so many thoughts, but I really want to capitalize on number one. When Scott said seismic, I don't know if it came through because I can obviously hear it. There was a huge thunderclap here in Texas because we're in the middle of a thunderstorm, so I thought that was very fitting. The heavens agree. This is monumental, the level of information. And I want to kind of camp on something for a little bit, Scott. I agree with you that things get implemented at their own rates in their own communities, right? I get that. However, these findings were just published, okay? They're new, they're exciting. There is excitement behind these, and there is momentum behind this. And you, the person with your earbuds in listening to us right now, this is an opportunity where if you have been working in your community and you feel like I am just not getting where I want to be in a timely fashion or as fast as I want to, maybe this is that pivotal next step of how we leverage those relationships and the communication and the networking that you're building in your own community to make these things happen. Because again, it is not just physical therapy shouting into the void saying how important exercise is. Like, this is so much bigger than any one of us, than all of us together. Like, this is changing people's lives. It is saving people's lives. It is giving people's lives back to them. And we have a real opportunity to step up to the plate and do something with this now. Because the last thing that I want is we have all this excitement and all this amazingness coming out from this research that was published, only for it to kind of fizzle out and for it to go nowhere. And if you're waiting for some big organization to come through and say, okay, everybody, here's how we're going to implement it, that's not how it works. It starts at the ground level in each individual community to help make this happen, to foster this becoming standard of care. It's not going to come, I do think there will be stuff that comes top down, but I also think a lot of this is going to be bottom up when it comes to the implementation of this, especially if you're in a community that you don't have a major academic institution where rehab is embedded and all the things that we know and we want and we love for our patients and ourselves to have. That may not be your clinical reality. it's on you, the listener. It's on me. It's on Scott. It's on everybody to actually make this happen in our own communities. So we need to harness the excitement and the momentum and the motivation that we as an oncologic community have in the aftermath of ASCO 2025.
Yes. And I would 100% to everything you said. And what I would hope is that by listening, we can empower everybody who's listening and empower our colleagues, especially the ones who are in smaller communities that are not necessarily near large academic institutions, to send that email. Send that email to the local oncologist and you tag this study. Because when other oncologists are putting it out on their LinkedIn and on their Instagram and everything, you know that it has caught the eye of so many oncologists. So that's great. That's incredible. And so, but the change does start with us.
Right.
And to start that conversation and to include this study and say, now here's the evidence that was, and that's, again, that's speaking oncology. You're speaking their language. When you say this was presented at ASCO 2025, that's going to get their attention versus this was presented at APTA CSM. They don't know what that is, but they know what ASCO is.
Yeah. Yeah. And again, 44,000 attendees. Listen, APTA CSM is no like little party, okay? It's big. This is bigger. And again, I think the choice, and I truthfully don't know who all was on that study. I've looked up some of the authors, but the fact that this was presented at a medical conference, I think is only better for us in the long run, because again, more eyes on this study, more eyes in places of referrals. Not that we should rely on referrals, y'all, okay? But more eyes who are potentially in positions where they can start saying, okay, we're going to implement this. We need to make those connections happen. But that needs to be met, like I said, by that bottom up approach. And not, again, this is not to say like PT is beneath MDs. That's not what I'm saying at all. But again, the grassroots movement needs to meet the coming down from the leadership entities and whatnot, the professional organizations like ASCO.
Yeah, I agree. And I think the other thing to consider too, again, for our colleagues who are in maybe smaller communities is, and I think we've talked about this before on previous podcasts, is that, if you can tag the patient voice, actually that's what we led with today, the patient voice. If you get that one patient who said, I went to Elise because I was super deconditioned after 12 rounds of FOLFOX chemotherapy because of my colorectal cancer. She got me moving, and now not only is it easier for me to go up and down the stairs to do laundry, but now again, I can walk my daughter down the aisle for her wedding in 3 months. That gets people's attention. And then you attach this study and it's like, oh, there's the evidence behind it. Yeah. Elise is not just pulling this out of thin air.
Exactly.
This is real.
Exactly. Oh my gosh. Again, we love a good anecdote, but 900 participants in this.
15 years. Over 15 years. Yes.
Oh my God. Okay. There was some really big stuff that came out of ASCO. And obviously, like we've said, this is like the holy grail when it comes to cancer rehab for us. Going back now, like you have left ASCO, you're going back into your own community. You've been back for like a week now. What are some of the big takeaways or the things that you're going to now be implementing in your own practice, in your own community with your own patients?
Yeah. So I left ASCO on Monday, and on Tuesday, an email chain had started to say, we need to get all the players in the room to start thinking about how we're going to implement this, including that GI doc I was just telling you about before. So, because he's a big proponent of exercise. So it started within 24 hours, which is great. And so we are going to meet in a couple of weeks and just start talking about how can we, again, I don't know that we're going to be able to get $50,000 worth of gym equipment right off the bat, but even just figuring out how to get those patients, to rehab a little bit faster,
Absolutely.
some sort of
Absolutely.
automatic referral, like, oh, if they're going to get oxaliplatin as part of their chemotherapy regimen, because we got to make sure that we take care of or address the neuropathy aspect of things.
Right.
Okay,
Right.
great. That's what EMR is supposed to help you with. So that's one thing right there. The other thing the other breakout that I actually went to, it was actually a working group for the adolescent young adults,
Yeah.
for an AYA population, and I really was in the room of all the who's who's, like the founder of Elephants and Tea, and representatives from Stupid Cancer, and
Yeah.
Dr. Michael Roth from MD Anderson, and John Salzman from Wake Forest, and I'm looking around and say, oh boy, I really am here with all the bigwigs. But to come up with, again, to your point, Elise, about how do you get ASCO guidelines and to get them into the community. And so we're developing a working group to figure out, again, especially for our AYAs, they may travel to a large medical institution to get their treatment. But that's not necessarily where they're going to get their rehab from. They're going to get their rehab locally, which may be 90 minutes, 3 hours away from where they were. So we're trying to talk about how do we come up with a logo that's got a QR code that then, like, it's easy to just get that out to community-based oncologists. The oncologists don't have to have all the answers, but if ASCO can put together like a resource hub, and then the AYA scans that with their phone and it directs them there. So it directs them to Elephants and Tea, and it directs them to Stupid Cancer and Live Strong Fertility and all those resources.
Yeah.
Then great. So that email chain is going around right now also. So that's really exciting. So I think for us as OncoPTs, again, to take some time, and yes, there's great research that comes out of our own journals, but if you can peruse ASCO, the Journal of Clinical Oncology, again, there's not a lot of rehab that gets published in the Journal of Clinical Oncology, but at least to be cognizant of these new protocols, new drugs, what are they taking out of protocols? So again, when you have that conversation with the oncologist, you feel comfortable and competent to have that conversation.
And this is a slight aside, but one of the things that I've really gotten a lot of benefit out of over the past probably like year and a half is when I really started this, but I use the NCCN guidelines a lot when it comes to like writing oncology specialist bootcamp and whatnot. But they do a really nice, I don't know, like weekly or monthly email debrief where they kind of compile like what are some updates. And some of those are, the NCCN guidelines updates, but also different articles. And and this is to Scott's point, I like them because they talk about, again, what's kind of happening on the medical oncology side. What are they finding when it comes to like, hey, this treatment is working for this. And, here's the numbers behind that and whatever, because it's nice to know what's happening on the medical oncology side, the clinical oncology side of things, so that when my patient comes to me and says, I'm on this medication, I can say, oh, I know what that is. And more importantly, I know what kind of side effects to expect and what to do about that. And the same thing goes here for ASCO. And, I'm sure ASCO has like an email list that you can join. And I know we already have probably hundreds of emails in your inbox, but even just to do a quick glance on what's happening, what is relevant to me in my practice. I love a good abstract scan. And then I can, do what I will with that article. And maybe I, like bookmark it and I save it for later. Or maybe I just glance over it and say, okay, that was good. But something like Scott has said so many times in this interview of being aware what is happening, so that when your patient comes in and is asking questions about this, you can ensure that you're informed and you can then help them with whatever it is that they're coming in dealing with and specifically seeking your help for. So this is so exciting.
Yeah.
Oh my God.
And so maybe one thing just to, to interject in here too is that just like we have the app for when we're at CSM and you can search for, presenters, you can search for themes, that sort of thing. ASCO, same thing. And so it was easy for me to just put in young adult survivor.
Love
and it
that.
told me like which posters, which breakout sessions, that sort of thing. You can put in exercise or you can put in rehab. And so in the future, moving forward, I highly recommend if you can go once, if you can go to ASCO and just see it, feel it, experience it. Like I said, it's CSM all jacked up on Mountain Dew.
Oh my gosh.
But it's great. And there's just the buzz, the energy, like everybody's talking and again, you're also seeing researchers and doctors from all over the world. But you can search for rehab, you can search for exercise, you can search for, lymphedema, you can search for whatever you want to search for in the app to find out which breakout sessions to go to, which posters that you want to go visit with, and take that information and bring it back home to your patients.
Scott, I'm really excited to see what comes out of that, breakout session that you were part of with AYA, because obviously I know that that's a very, very special place in your heart, very underserved patient population. We've talked about this many a time on the podcast. We haven't really talked about your presentation yet. Can we talk about your presentation at ASCO and how did that go?
It was really nice. So there was the four of us, and the three oncologists were talking about the latest research in treating kidney cancer and how do you like imaging, like if a patient progresses, like how do you what's the protocols for screening, and they had a lot of polling questions, so they were putting it out to the audience, like in a situation like this, do you do Pembro in this instance, or do you not do Pembro in this instance? So it was really kind of interesting to see that. But then they would turn to me and they'd say, so what's going through the patient's head? And there was one point where they talked about surveillance. And they said, oh yeah, well, at this point, we would probably move the patient to surveillance. And my 2 cents was, surveillance can be a scary word.
Yeah.
Surveillance might be interpreted by the patient as, oh, well, now what? Very similar to survivorship in the sense of, for better or worse, you're at the cancer center and you're getting treated and you're kind of in that safe little bubble because you got nurses taking care of you and they're checking your blood levels and all of that. So you're at least got somebody keeping their eyes on you. And then if they say, okay, well, surveillance, you say, well, what if something happens? What if now, between now and 6 months from now, the cancer starts to grow again? Are my counts okay? Like all of that. And so that was, to that particular case, I said, you have to be careful. You can't just automatically assume that surveillance, that the patient's going to start jumping up and down out of their chair.
Right.
They might be a little scared.
Yeah.
And so surveillance might have to come with a caveat of, if you need anything, or we'll have the nurse check on you, call you in a month or something like that. That sort of thing. You can't just blanket statement say, you're on surveillance, hooray, see you in 6 months.
Right. That drop off, that's what my patients have likened it to. It's like a drop off a cliff of like, I'm falling and I don't know if I'm gonna get caught at the bottom or if I have like a safety rope or something. It's just kind of a big void that they feel like they're metaphorically going into. Yeah.
Yeah. So it was great. And so again, it was nice that they're integrating more patient advocates at this conference to have the patient voice heard. And, so my hope is that, as ASCO continues, and I would therefore also say for us at CSM, that we think about how can we include that patient voice, because the one thing that carries the most weight at the end of the day is how's our patient doing, and we don't know until we hear from them.
Yep. Absolutely. For the clinician who's listening right now and who's considering, maybe I should go to ASCO. Maybe I should go to ASCO next year. What would you tell
I'd say bring plenty of snacks.
Love
Just
it.
like you
Love
do
it.
when you do CSM, bring good walking shoes, like
Mhm.
all the fundamental stuff that you do when you go to a big conference like that. But I think also, because it can be overwhelming, go in with a little bit of a, not a hard and fast plan, but at least an outline.
Totally.
Maybe an outline is the best way to describe it. Again, go through the app ahead of time, do your search, see what you want to view, or what posters you want to go to, that sort of thing. But also walk around and listen, and maybe you find something that, like for me, like I'm not a lymphedema therapist, but if there's something that's like new, like I was referring to before, this new study where they're talking about potentially not doing sentinel lymph node biopsy in certain early stage breast cancer, maybe I need to go into that one, because again, I'm going to get those patients.
Right.
And so I need to be cognizant of that. Or I might say, oh, wow, I'm not seeing a lot of multiple myeloma patients. So maybe I need to go to one of those breakouts. So that way, when I go back home, I can reach out to those docs and say, hey, I was just at ASCO. I went to this breakout about multiple myeloma, and they presented this new drug, which all sounded well and good, but it causes neuropathy. You don't want your patients falling in the middle of treatment, do you? Send them to me.
Right.
So an outline is good to allow also some flexibility. And I would also then also say, for anybody who does decide to go to ASCO, give yourself a little bit of time to explore Chicago. It's a great city.
Great city.
So, you should have do a little bit of tourism while you're there. But yeah, it's great. And the other thing too about ASCO, if you stay at one of the many hotels on the Magnificent Mile there, that are all kind of affiliated with ASCO, they have shuttles.
Oh,
Yeah.
wonderful.
It's great. I never had to Uber over to the McCormick Center, because McCormick Center is south of the city.
Okay.
So, when you check into your hotel, you just ask them, what street corner does the shuttle come? What number of shuttle is there? So I had shuttle number 5, and it was right outside my hotel, and they run like every 15 minutes because you got to get 44,000 people there. So that was nice.
Okay, I would like to formally petition to have CSM in Chicago so we can have those shuttles. Listen, I love a good public transportation, but like trains and whatnot, but shuttles?
Yes.
Next level. I need that. Yes, please.
Yes. Yeah, like I said, it was great. So,
oh my gosh. Very, very cool. So this was your third time going to ASCO. Do you think your experience has changed at all over the years of, going first pre-pandemic as, a patient advocate, and then as you've gotten, you've become a specialist, a board certified specialist in oncologic physical therapy. You're now involved in a lot more speaking and teaching opportunities. Has that shifted any of your experience at ASCO over the years?
Yeah. This year I did not feel as overwhelmed, again, because I've gone a couple of times.
Yeah.
And again, working hard to create these relationships with other people and with doctors and that sort of thing. It was nice to bump into a few people. I did have a fanboy moment. I did bump into Dr. Liz O'Riordan.
Who we love.
And I was like, all I said was, it's great to meet you and thank you for all you do. Like, she doesn't know me from anybody else, but so you see people like that we all follow, right? On social media or whatever.
Yeah.
But again, we do belong at that table, so don't be intimidated to be there, because again, at the end of the day, who's going to get these patients moving again? And who's going to get these patients stronger? And who's going to get these patients to return to a good quality of life? It's us.
Yes. 100%. Scott, this has been a really wonderful conversation. Is there anything else you want to leave the listeners with about ASCO before we sign off for today?
Again, I would just wrap up and say that in order for us as oncology physical therapists to treat the whole person, we have to work together with the other providers. Again, the doctors, the nurses, the social workers, the dietitians. So we all have to work together. And so I think the more that we can collaborate, the more that we can kind of step out of our comfort zone sometimes and go to these other conferences, it's enlightening, and it is also energizing for us. So I think it also validates what we do as oncology physical therapists. And it also, again, it gives us, at the end of the day, it also gives us an opportunity to look at the opportunities for oncology physical therapy to treat these patients.
Oh, okay. That was it. That might be your soundbite for the episode. I love it. I will also link to the studies and the information that we talked about in today's episode. I will link those in the show notes, which you can find at the oncopt.com/podcast. And if you go to the specific episode, that will also be there for you. I know we talked about, obviously, the challenge trial. There were others that are so worth your time in just diving into and exploring and seeing again, how is this relevant to me? How can I implement this in my own practice, in my own community, for my own patients? Really exciting stuff coming out of ASCO 2025. It's going to be really wonderful to see what continues to come out, how it is implemented into practice, and how our colleagues across the country are using this information. So I'm very, very excited about this. Scott, thank you so much for coming on the OncoPT podcast once again. Would you like listeners to connect with you or follow you somewhere so they can continue this conversation?
Yeah, so I am at Scott Capozza at both Instagram and LinkedIn and all the social media platforms. Alicia, you're free to share my email as well in your episode notes. And I will, if not now, then definitely, in future CSMs, happy to connect.
Yay! Well, thank you so much, Scott. And until next time, this is Elise with the OncoPT. And remember, you are exactly the physical therapist that your patients with cancer need. So let's get to work.
Thank you so much for listening to this episode of the OncoPT podcast. If you'd like to help support the podcast, please share it with others, leave a rating and review, or support us on Patreon.